صباح الخير يا بابا.
صباح الخير أروى، إن شاء الله تمام. كويسة؟ الصوت ما واضح؟ الصوت ما واضح؟ ما واضح الصوت؟ ما في جوين. أروى ألو؟ ألو؟ ألو؟
Yes, Prof. We can hear you.
معين؟ أوكي. أروى معانا عشان السلايدز. أروى وطعت. ربع جاهزين؟
بروف صوتك ما واضح. ربع دي سامعة صوت بروف.
الصوت ما واضح؟ الصوت ما واضح؟
شباب صوت بروف واضح.
ما سامعين؟ سلام، ما واضحين؟
نحن سامعين وشايفينك يا بروف.
طيب أروى ما سامعة. أروى معانا؟ طيب أروى يمكن عندها مشكلة بالنت بتاعتها. طيب نبدأ. Welcome to this Sunday lecture, which is continue on infectious and tropical diseases. This lecture is a continuation of HIV/AIDS, which we started last Sunday. صوت مسموع يا ربع؟
Yes.
Okay, so we continue. HIV/AIDS is, I think, I call it the disease of the century, because although we have COVID and all the deaths from COVID and all the socio-economic retardation caused by COVID epidemic, but still HIV/AIDS is the disease of the century for many reasons, because it's a chronic disease, it has been with us, it has killed so many people, and particularly it is very difficult to control. I think up to now, unless you have a vaccine or a cure, a drug which cures or kills HIV virus, then we are not safe. Up to now, we have means of making the disease chronic, but tolerable, but not eradicated or eliminated in patients. So it is a disease which is going to hang on with us for some time. and it's draining a lot of resources. So it is a disease which is important to the extent that United Nations, as you know, has created an organization just like ILO or WHO, UNCHR, Lajin. Those are the United Nations organizations, and this is the created UNAIDS, United Nations AIDS Program, and this is now is a giant. Many of the recommendations and guidelines for treatment of HIV/AIDS comes from either WHO or from UNAIDS. It's a medico-social problem, and I think I would like to emphasize that it is a social problem. It's a social disease, which very much depends. The epidemiology and the spread depends on social norms and social practices, and it touches on the most important or second most important desire of human being, which is sex after food. So with that, I think it's a disease which really is dominating our world now, and people who are studying or training in Tanzania, or in Rwanda, there is a special department called HIV, AIDS, and tuberculosis. This is a specialty which is now very well recognized. Okay, after 1986, the disease was turned by antiretroviral therapy into from an inevitably fatal disease to a chronic manageable disease. And this is in itself is a triumph and victory over tragedy. So it's a progress, and the epidemic was halted by the antiretroviral therapy. Over 80%, over 80 million have contracted AIDS, and almost half of them died. And the epidemic has stopped or has declined. Unfortunately, in the last 2 years, there is a very minimal decline of number of new cases, by 5-6% only, which means we are reaching the bottom trough of how far we can go with the current means of control and treatment. Statistics will tell us that now we have new infections, about 4,200 every year, new infections, and these are mostly in Africa. Up to now, 80% of all people living with AIDS, and this is a terminology which is commonly used by United Nations, WHO, and others, people living with AIDS. Okay, there are 80% of them are in Africa. So it's still a disease. It's not a tropical disease. It's a worldwide disease, but more so, it has its importance in the tropics or in Africa. So beware. Secondly, it is a disease which has activated a lot of other diseases, mainly tuberculosis and opportunistic infections like cryptococci, toxoplasmosis, atypical mycobacterium, and it has researched some of the malignancies, especially if you have very, very severe infection. People can develop non-Hodgkin lymphoma and Kaposi sarcoma. Kaposi sarcoma was not very common before HIV/AIDS. We talked about the clinical features and manifestations. Very complex. Its complexity came from the opportunistic infection, which is O capital O-I, S small s, O-I-S, which opportunistic infections. And this is one of the main causes of mortality in HIV/AIDS, particularly tuberculosis. This is why the current regime or current guidelines of both WHO and UNAIDS is to start antiretroviral therapy very early, to the extent that if you diagnose the case today, you have to start it today even before recovering the investigations back. You take the investigations, but you start the antiretroviral because very much is dependent on the drug. And the two factors which we will measure the severity of the drug is the viral load, which is except in copies per mil. We say 400 copies, 400 virus per mil, or CD4, which are cells, CD4 cells per mil. So these are what we measure our criteria for lowering. So the most important limiting factor for good prognosis and for prevention of death is decreasing the viral load. That is extremely important. This is how the drugs have impacted our thinking and our knowledge and the epidemiology of HIV/AIDS because it reduces the UNAIDS have had a capital U equals capital U. And if Arwa is there, she can give us that in a slide form, just to remind you. Is she there, Arwa? Okay. Capital U is undetectable virus, okay? Equals untransmissible virus. So if you don't detect the virus, you cut the transmission or you transmission, okay? So it's U equals U, undetectable equals untransmissible. So the important limiting factor for the spread of AIDS is viral, measured as viral. Okay, what is CD4? CD4 is a lymphocyte, is a cell, okay? And the cell could be lymphocyte, could be microglial cells of CNS, might be dendritic cells of the nervous system, or might be macrophage. And these are the ones which carries the molecule or the protein of CD4, okay? So CD4 is on the top of these cells, okay? It's a protein, it's a receptor, okay? It's a receptor for the virus. So the virus will look for CD4 on cells, and these are mainly the lymphocytes, but other cells, as I mentioned, they can take the virus. So it seeks the CD4 virus, CD4 cells, and they hang on, they get fused, and they get entry to the cell, which is mainly the lymphocyte. There is another protein which is called CCR, capital C, capital CR, 5, which is CCR5. This is a co-receptor, and this will allow binding of the virus, okay, and fusion of the virus, and then entry to the. So you need CD4 and CCR5 for the virus to get into the cell. Unless it gets into the cell, it's can be transmitted, but it cannot replicate. So the most important thing is that the virus will replicate into billions, okay, and then gets out of the cell, or the cell is broken, lysed, and the virus will come out. Okay, what does it do to replicate within the cell? If there is if you can get this picture, okay, this is the cell. If you can see it, the cell has an envelope, which is the thick outside, which is an envelope, and this is from human plasma. This is the cell uh, which has efflux itself from inside the lymphocyte to the serum. So it coats itself with the serum there. And if you can see that it has a capsid, the capsid is the long one, it's around, and then it has the genetic dimer, which is RNA dimer, which is in the middle there. And these are the components, the genetic components. So it has the capsid. So that, and there are there are 4 enzymes which you can read them is transcriptase, which is reverse transcriptase. That's number 1. Number 2 is protease, and then number 3 is integrase protein. These are very important enzymes. I will say them again. It's reverse transcriptase, which is here, transcriptase enzyme, and then the reverse transcriptase enzyme, and then protease enzyme, and integrase enzyme. And all these enzymes, these are the enzymes which are being targeted by the drugs. Well, what we have is reverse transcriptase inhibitors of 2 types. Transcriptase, either the nucleoside and then nucleoside. These are one group of ART or antiretroviral therapy. And then we have the protease inhibitors, and we have the integrase inhibitors. And the integrase inhibitor and U-integrase inhibitor, which is being introduced, has made a great success, an uphill of treatment for antiretroviral. This is dolutegravir. Dolutegravir, we'll get the names back, but if you want it, it is an integrase inhibitor, which is making a real advance, because one of the problems with antiretroviral therapy is resistance. And this one resists the resistance of the virus. So CD4 is a receptor, capital CCR5, which is a co-receptor. The cell can get in mainly in the T lymphocyte. This is why the T lymphocyte is the master of cellular immunity. So if you knock that out, or you knock it out, then you are in trouble. But the body does not give up. Okay. So if the virus gets in, the body will fight. It has a very strong fight. Okay. The initial infection will be like a flu-like. That's what we call seroconversion. This is very early. And not all people develop seroconversion. It's about 40% to 90%, which we call acute seroconversion illness. And this lasts for 2 weeks. I know I have outlined this in the lecture before, but as clinicians, I think this is the most important part for you to learn, because then as doctors, we are entrusted to pick up AIDS as early as possible. Okay, so it is an acute illness with fever, fatigue, myalgia, okay, headache, and pharyngitis, okay, maculopapular rash, and oral and genital ulcers with generalized lymphadenopathy. I think those will subside, in 2 weeks, but the lymphadenopathy can be there. And the lymphadenopathy is an important feature of HIV/AIDS. But you can also have in that, which is some neurological problems like meningoencephalitis or peripheral neuropathy, which is like Guillain-Barré syndrome. But this is self-limiting. This phase is self-limiting. If we are sure about HIV/AIDS by testing, the WHO advice is to start treatment. The general law is to start treatment wherever you get a diagnosis. So it is important, and the gap between your decision to start treatment and the start of treatment is very crucial. So that goes. Then you have the period, which is a very long period, about years, up to 8 years. The virus will be there. It's not latent. It's not dormant. It's multiplying. It's replicating, multiplying within the cell and outside the cell. Once the cell dies, it causes the immune depression because T lymphocyte is important for cellular immunity. Then all depends on the degree of how many CD4 cells are being knocked out. So it's if it is, up to 500 and up to 1,400, these are the normal CD4s. But if it goes down like 300, then you will have the opportunistic infections, especially TB will get up and will become active. So, and if it goes below 100 CD4 per mil, then you are susceptible to get, also the patient is susceptible to get tumors, especially non-Hodgkin lymphoma and Kaposi sarcoma. Okay, so it's very, very important to remember that the two tests which we will do is CD4 and viral load. Okay, the third after the asymptomatic, then the stages become the stages, which is WHO stages, become very clear. Okay, so we have the clinical stage. It is 1 to 4, the stages of WHO in 2010. So stage 1 is asymptomatic, we said, and then stage 2 is as the um, CD4 drops down. If the CD4 drops down, then you get unexplained persistent hepatomegaly, lymphadenopathy, and then you get papular rash, you get infections like herpes zoster, fungal and nail infection, and then you go on for stage 3, which then you get thinning, and there is loss of weight. Which is remarkable, and then you get persistent diarrhea. Then the diarrhea used to be more, or should be more than 14 days, and then you have pulmonary tuberculosis, lymph node TB, symptomatic lymphoid interstitial pneumonitis, and lung bacterial infection of lungs and unexplained anemia. So these are, now we are progressing from one stage to another, and the last stage, stage 4, is the morbid stage with the patient becomes so thin, chronic infection, extrapulmonary tuberculosis, Kaposi sarcoma, then you get toxoplasmosis, cytomegalovirus infection, and extrapulmonary and pulmonary cryptococcal infection. Okay, these are the very important cause of death. In stage 4, we can also get cardiac problems, particularly cardiomyopathy and heart failure. This is the last stage where CD4 is below 200 or even below 100. Okay, then you have a cerebral deficit, cognitive function, The patient becomes, aware of dementia, and even on MRI, the brain is small, okay, for affection of the central nervous system. So it is number 4 is associated with central nervous problems, diminishing size of the brain, and peripheral neuropathy, but dominated by opportunistic infection. You can have the cytomegalovirus, the coccal infection, tuberculosis, either in the lungs or outside the lungs. These are the 4 stages which is being devised by WHO. It's been changing. I think I have to remind you that the guidelines, although coming from an international body like UNAIDS or WHO, but it has to be tailored to the community or to the area where we live. Okay, the best example is breastfeeding. Breastfeeding is an important method of transmitting the disease from mother to child. Okay, but you are in a dilemma. Okay, if you breastfeed, you have a 40% chance. If a mother is positive, it has a 40% chance of transmitting HIV to the baby. Okay, this is a fact. But the fact is, if we don't breastfeed in Africa, where food is not clean, milk is not clean, milk is in short, food is in short, flies are there. The case will be against stopping breast to think. This is why guidelines for individual country is very important. Is very important. So it's something which is very tricky, very tricky. And the whole social setup of HIV/AIDS is very tricky. The social norms are very variable in the world. For example, I mean, homosexuality, gay, in countries like America and Europe, it's what they call sexual preference. Sexual preference. They don't call it even men having sex with men. Okay, they don't call it. It's gay. It is a preference, and it reached the level that in the G7. G7 is the big leaders of the world. There are 7 countries, now it's expanding. But during a G7 meeting, one of the presidents came with his boyfriend. He's not a boy, he's a man friend. Okay, an old man going with an old man. And in a meeting like that, these are really the top world. So, and if you want to win USC nomination for president or an election for president, then you have to support gay movement. So that is one end of the norms. The other end, if you come to the religious countries, Muslim countries, even Christian countries, okay, Catholic countries will stand very, very strong against gay. So that is the difference between one norm and another norm. Secondly, it is very much related to sex, very much related to sex, not only homosexual, but heterosexual. True, the homosexual is higher risk, especially the receptive man or receptive boy. It has 1 to 72, okay, while the receptive woman has 1 to 1,250. So gay are more prone. Even the insertive person has a higher, very, very much higher risk than the insertive or the male with a female. So how can we, address the social setup of patients to prevent HIV/AIDS? So if you are to respect the norms, then you have to accept what is available and provide control according to what is available or to what is being accepted by the community and by the leaders of the community. Uh, we go back just to remind that HIV/AIDS is transmitted either vertical from mother to baby, or horizontal by blood products. If you are exposed to the blood, then it is a risk. Okay. Thirdly, particularly needles and drug. People who are using drugs or have been using shared needles, then this is a risk. And in the new cases, HIV new cases, we reckon that 10% of all cases new are due to drug injection, all right, to opiate or morphine or whatever. These are injected, and often people use shared needles. Okay. How before I come to the treatment, okay, before I come to the treatment, I just want to outline some of the complications. You may say complications of HIV in the body, or it may just be part of the clinical picture. We already mentioned the neurological, the dementia, the cognitive function, depressed, the small brain, the peripheral neuropathy, just like Guillain-Barré syndrome, and you can get seizures, convulsions, seizures, epilepsy, and psychosis. So it can even reach a level where patients should be taken to the psychiatric detention. Nephropathy is again very important. This is nephrotic proteinuria. Nephrotic proteinuria. All right. It starts as cells being damaged and the heavy protein, but because there is also a lot of sodium, there is very little edema. If you lose protein, like nephrotic syndrome, you get edema. You get edema of the legs, of the face. But here, although you lose protein, but you lose sodium, and it is non-edema protein loss. But this can progress into renal failure. The heart can cause is cardiomyopathy, and 50% will go into heart failure. So it's a disease which can affect many organs. Aging, you can age prematurely. With aging, you can get multi-morbidity, and at that time of aging, if you are using the antiretroviral therapy for 10, 15 years, then you have to pay for the side effects, the chronic side effects of the drug. And that at that level, you live long, patients live long period, then malignancy can occur, particularly non-Hodgkin lymphoma and sarcoma. By that time, again, the OIS, which is fungal, and tuberculosis is a major opportunistic infection. So the department is AIDS and tuberculosis, because they are very linked together. And the outsurge of tuberculosis, even in New York and others, where they control tuberculosis, the upsurge of patients with tuberculosis is due to HIV/AIDS. And rarely, or not rarely, but you can get non-typical tuberculosis, mycobacterium tuberculosis of others. Cryptococcal infection is very common. It can cause lung disease, it can cause meningitis. streptococcal meningitis, which is common with untreated HIV/AIDS. This is a fungal infection, and human is affected by inhaling the cyst from the ground, and then it goes on. Okay, for all these complications. Toxoplasmosis is another. Toxoplasma is protozoan infection, which can be in the brain, and it can affect the low immunity. In the brain also, you can get a space occupying lesion like by toxoplasma or by cryptococcal infection, or even by tuberculosis, tuberculoma. It gives you a space occupying lesion effect. And a space occupying lesion effect is headache, severe headache, especially morning headache, blurring of vision. You may get seizures and papilledema. This is SOL, which is space occupying lesion. So whatever you can just revise your medicine and see what an infection causes, and then you can draw the symptoms and signs. So always remember that super infection is extremely important and limiting factor in the death and mortality of patients with HIV. Sorry. Okay, control very much depends on the setup where you are living. The transmission is either through mother to child, through blood transfusion or blood-related infections, ulcers, or it can be due to heterosexual or homosexual. Condom, what does it do? The condom protects to a very large extent from contracting the HIV/AIDS. So it's what we call safe sex or safe practice of sex is using the condom. But again, this is again depends on the social norms, like how do they perceive the, the how the community perceives the use of condom, and people will claim that it's the use sexual desire, sexual ability, not the sexual ability, the sexual pleasure, and they have the belief that it doesn't do a great job. It does. But whatever people feel about it during sex act is depending on the community and the personnel. So unprotected sex is not advised. So whatever we are, wherever we are, then protected sex using condom. The problem is condom. If they are of all type, they can rupture and they can cause havoc. Number two, obviously, if you have other sexual transmitted diseases, then this will make the patient more prone to HIV. If you have syphilis, gonorrhea, then that is the case where you can contract HIV easily. If there are ulcers, even if there are ulcers in the genital region or for sex, like rape, then that will make tear on the sexual part, and this will allow the HIV to go. So it's a state of complexity. HIV/AIDS will take the opportunity from the body, ulcers, here and there, sexual transmitted diseases here and there, very much associated with hepatitis B virus, because as you know, hepatitis is through the blood transfusion. So who are more prone, obviously, those who are receiving blood transfusion regularly on regular basis, like people with anemia, chronic anemia, people who are receiving blood components like hemophiliacs. Okay, so these are the ones who are to be catered for. The other group of people are the professionals who are exposed. You have to treat patients with HIV. A lady who needs a cesarean section has to have a cesarean section, even if she is HIV/AIDS. But precautions in the theater is mandatory. People use more than one glove, and if it is very high risk, then you can even have what we call pre-exposure prophylaxis. Pre-exposure prophylaxis. Or if you are being even really stick into your finger as a surgeon, or even if you are a nurse or a doctor, then you could have post-exposure prophylaxis. And these are, according to the guidelines, two drugs, which has been the pre. You have to have it at least a week before, what we are expecting to have. Okay, if you are to have sex with somebody, he's well, maybe suspicious of HIV, you can have 7 days, before they act, and then at least for 6 weeks after. So the 7 days will concentrate the drugs in the areas which are of concern, which is in homosexuality is the rectum, and in heterosexuality is the vagina. Okay, so you need a high concentration of the drug in that, and 7 days can do it 6 days only, 6 weeks after that. So that is the pre prophylaxis, pre-exposure prophylaxis, and it is written P capital E and then P pre-exposure prophylaxis. P. Okay, that is the one before. But to me, I mean, if you know that the patient is HIV, you have to abstain. You have to abstain and look after yourself. But if you are a doctor or a nurse, you may be a needle may stick in or be stuck in your finger, and then that is will cause worry. Is what we call post-exposure prophylaxis. And then there are used one drug or two drugs, and then for a month, and then 3 months later, you can have a test to see if you are positive or negative. The risk of getting by a needle, which is contains HIV, is only 0.3%. It's only 0.3%. But if you go for HIV, if you are stuck with a needle which contains blood from an hepatitis B virus, then the chance is very high up, like 20%. And we see hepatitis C, if you have stick in the needle which contains blood of C, then you have about 10% chance of getting hepatitis C. So, despite the fact that HIV is a severe disease and very dangerous disease, but the needle is not that high, because the worry about the needle is even more than the worry about hepatitis, and people try to neglect hepatitis B. Okay, for the prophylaxis, if you have to start immediately post exposure. If you don't start up to 72 hours, 3 days, then you had it. any benefit if you do that. Okay, so one of the fairly recent findings in control of HIV is circumcision, male circumcision. And there were very big trials. I'm very proud that Dr. Professor Taha Taha from Hopkins University used to be in public health university, public health, a teacher in Faculty of Medicine, Khartoum. He immigrated to Hopkins and he became a very well-known public health expert. He did a trial in South Africa, very big trial about circumcision. And they found that adults who are circumcised, adults obviously who are practicing sex, if they are circumcised, they will have a 60% reduction or chance, 60% less chance of contracting HIV. And this is major development. So it is important that to bear in mind, نحمد الله, this is a religious practice, male circumcision, but now people are coming to it. In 10 years, you know, from 50,000 people circumcised after this came out, in 10 years, 23 million people were circumcised. This is what they call surgical circumcision. Okay, ours, when people are children, you know, males are children, they get circumcised. This is a religious circumcision, but it is the same. But they just wanted to do it like, you know, we don't do it for religious purposes. We do it for, as I said, because just like you have an appendicitis and you want to take it, okay. So it's a very important feature now in control of HIV/AIDS. So to control HIV/AIDS, you have to use the ABC, which is abstinence. B is be faithful. C is correct condom use. Correct condom use. So A, B, C. If you can't do that, then you have to use protective measures like condom. Okay, you can avoid the needles, avoid blood, you know. And if you have a prick by blood, then let go for the blood. Don't squeeze it, but let it go and wash it with water. Don't wash it with alcohol or iodine, okay, because that will irritate the wound and it will get the virus out. Okay, so, and then if you think there is a high suspicion or the patient is positive, you can use post-exposure prophylaxis. And then there is guidelines for that, as I mentioned it earlier. So for mother protection, is during pregnancy, the highest period of transmission from mother to child is the third trimester more than the first, and during delivery, and then during breastfeeding, the breastfeeding. The breastfeeding is, you know, that milk is, contains HIV from mother, but then the closeness of the mother to child, then that is, if a patient is positive and is very close to somebody, then this is a risk. This is a risk because you never know if there is a wound, there is an ulcer here and there. But the fact remains that milk can transmit the HIV. You remember the fluids which transmit HIV/AIDS are obviously semen, vaginal secretion, okay, blood and all blood contents, Okay, amniotic fluid, and this is again during delivery, if there is a gush of amniotic fluid, يقولوا الحاجة انكسرت الحاجة كسرت زي البلد come. If you have an ulcer somewhere in the body and you are not wearing protective gloves, then that is a risk. So amniotic fluid, pleural fluid, pericardial fluid, the saliva is not. Saliva is not. Okay, tears is not. Sweat is not. Urine is not. Feces is not. So you know those which are positive and those which are, they're not. Because this is again for fear. Don't get over excited, not over the with the fear from HIV/AIDS, and then that will affect your life. That will affect your life. So know those which are you can contract infection and those which are not. With mothers, as I said earlier, then we can give the mother antiretroviral therapy, during pregnancy, it's not contraindicated. We can then, after the baby is born, we can give the baby, antiretroviral prophylactically for a period, till he's up. Test, always test, okay? And now we have the self-testing because there is a stigma. Not many people go to the clinic to say, well, test me for HIV. So this is why you can buy a test from the pharmacy and then do the test yourself. Obviously, it's not as accurate as the test in the lab, but it gives an indication. If 3 tests are positive, then better. The suspected should go for a better test. And the tests are, now they have tests. It is very highly specific for HIV/AIDS, and we don't even resort to Western blot, which we used in the early time of the epidemic, because now the tests are refined and become very, very effective. Okay. Lastly, I think we have about 10 minutes to go. I would like to talk about the antiretrovirus, because this has made a change, a dramatic change on the epidemic of HIV/AIDS and about the life. And as we earlier said earlier, that this disease has been converted from an inevitably fatal disease to a chronic manageable disease, manageable, obvious, with drugs. So antiretroviral drugs, when it was first introduced, it was the drug first introduced was AZP, and this is now I'm talking about drugs which are very difficult to pronounce, this is why now they are calling them by the application. Okay, like the first drug was zidovudine, which is called AZT, and this was introduced in 1986. So the basic principle, pharmacological principle, is these drugs are inhibitors of one of the 3 enzymes. The enzymes reverse transferase, reverse interferase, that is the 2 groups, which is nucleoside and non-nucleoside reverse transcriptase inhibitors. Reverse transcriptase inhibitors. Okay, there are 2 groups. And then you have one group, okay, which is protease. That is another enzyme, protease inhibitor. And then integrase inhibitors. Okay, I wrote to Arwa about these are the groups that are now used, but there are so many. When to type the slide, and she said, well, I found more. And it's true, there are which are now produced as antiretroviral therapy. But these are the ones which I already sent it to you. These are the ones which are in common use. I think we have to say that these drugs has to be used for life. No doubt about this. Well, if somebody stops taking it for a few days, then viral replication will take place. So that's important. So it's the compliance is very important. So if you are in a clinic of HIV, one of the monitoring of the patient's care is compliance. Is the patient complying with the therapy as it is being prescribed? Compliance, compliance is sticking or adhering to doctor's instruction. Compliance is adhering to the doctor's instruction. And if the doctor says take 2 drugs, you take 2 drugs. If it is 3 days, three every day, then there's 3 every day. And the first thing in the clinic, when the patient comes back with his drugs in a pocket or in carried by him, then you have to count the drugs and see if compliance is correct or not. So secondly, now we know because of fear of resistance, we use more than one drug. The classical is dual, 2, if it contains this new drug, which is dolutegravir, which is a protease integrase inhibitor. So you can use 2 or you can use 3. This is to diminish resistance, and this we have been doing for quite a time now. Tuberculosis is given all those 3 or 4 together, which will shorten the period. Number 2 will prevent, because you are attacking the virus or the bacteria in different places. This is why it will not find livelihood to overcome the drug. So it is important. And even in malaria, ACTs, okay, artemisinin combination therapy is a combination therapy which is used again to avoid resistance. So that is number 2. Generally, these drugs are, good tolerance. People tolerate it very well, but there are some side effects. Which we will highlight in a minute. Okay. So the drugs, the uptake of the drugs. You think that if patients had AIDS, then they will run for the drugs. That's not the case. That's not the case. The uptake of the drugs is low in certain countries. Just 30% people who have AIDS are not going to the clinic to get the drugs. And this is become on the shoulder of the medical profession. Certain countries, only 30%. Other countries, they pick up the drugs up to 75%. Well, in Europe, it is different, almost 90%. And UNAIDS have done a strategy for 230 years, that 95%, that is included also in the sustainable development goals, that 95% of people should know what is their status regarding HIV. 95% of those who know that they have HIV, they should take the drugs. Okay, and then 95% reduction from vertical transmission mother to child. So these are the goals of DNA. So it depends very much on the drug and the provision of the drug. The drug, as we said earlier, is given free by the Global Fund. So it's just a matter of healthcare system, if it is strong, if it can reach all patients with HIV, then this is important. The treatment is not only antiretroviral. It has to combat and has to go a long way to treat tuberculosis. And now we accept prophylaxis with INH in all patients or most patients who have a depressed CD4 with isoniazid. Secondly, the fear of cryptococcal infection, we can give cotrimoxazole for life. Can give cotrimoxazole for life. These are prophylactic drugs against cryptococcal, cotrimoxazole, and tuberculosis. So these are the most two common opportunistic infection. But if you have a specific other infection, then you can treat bacterial infection, toxoplasmosis, whatever, then that has to be treated accordingly. So other drugs are to be given. If Arwa is there, if you can have the slide about the antiretroviral drugs. She's not there, she's not showing it. Okay, these are drugs which I already sent it to you, and the reverse transcriptase inhibitors is of two, the nucleoside type and the non-nucleoside type. The nucleoside type is tenofovir, abacavir, zidovudine, lamivudine. Lamivudine is also used against hepatitis B and C. And then the non-nucleoside is nevirapine, efavirenz, and then the protease inhibitors are also, like tenavir, okay? She will show them. And then the protease inhibitor, tenavir, they're there. She said that they are being shown to you. So the protease inhibitors, you can read it out from the slide. I don't see the slide anyway, but I have it written in front of me. So it's lopenavir, that is the protease inhibitors, ritonavir, atazanavir, and doronavir. So these are the drug protease inhibitors. But the integrase inhibitors, the one recently had made the change in ART, antiretroviral receptor. And this is mainly the dolutegravir. Dolutegravir is the one which is now used, and this have changed our concept from 3 drugs to 2 drugs, provided that it will contain dolutegravir, which is dolutegravir, dolutegravir. So this is an integrase inhibitor which is being used. Okay, to make it easy and to make the compliance better, now there is fixed dose 2 combination. So in one tablet, you get a fixed dose of one nucleoside or non-nucleoside and non-protease inhibitor. So you get 2 drugs in one tablet. And this will make the compliance much better. Or if you're taking one drug, your compliance is better than 2 drugs. If you take 2 drugs, the compliance is better than 3 drugs. So with that, I think it's that antiretroviral therapy. So the management of the patient is social, okay, social education, social awareness, and then that is continuous. It's not something which we do on HIV AIDS day, because there is a day, and the day is just a reminder of the presence of the disease. Okay, but socially, the health system should care about HIV patients. They have the clinic, which is very nicely done here in Rwanda and Tanzania. There is these clinics which people can get enough treatment, pre-treatment, pre-diagnosis. But socially, there are a lot of NGOs, a lot of good wishers who can go around advise about safe sex, about condoms, about taking drugs, and about abstinence, A, B, C, and all the rest of it. So it's important, it's a social and community responsibility to prevent HIV/AIDS. Okay. The use of condom is not easy. You know, I'm talking to you like doctors now, but the public will not know about condoms, will not know how to use the condom, and what are the usefulness of the condom. So these are people who are activists in the community who can go and do a lot of education. Taking the drug again, this is another hurdle. Well, even if the drug is available, it's not being taken up. Okay, so that is something which people can work on. The purchase of the drugs is not now purchased, it's free, but even a free drug, if it comes, to the airport, you have to have a health system which will get it in and then distribute it, make it available. And then from the patient, the compliance is another story. Um, Circumcision is very important. It's, as we said, reduces the risk of infection by 60%, and it is advisable to be as early in life as possible, as we do it in the Muslim world, because you don't know when puberty comes, and you don't know when would a child of 15, 16 practice sex. So it is important to have it early, and early on after birth is now practiced in many countries, even in the UK. So circumcision is another way of reducing blood. Again, social activists and community activists should advise young people, against using drugs, against using needles. The third is, if you are a doctor, professional risk of getting HIV/AIDS, and have talked about it. The pricking of the needle, the surgery, and the surgeons, and those who assist the surgeon in a patient's HIV. There is pre and there is post exposure prophylaxis. Third avenue of control is the mother to child, and this is a special. Pregnancy is an immunosuppressive state. Even normal pregnancy is an immunosuppressive state. So what we should do is to care about the mother generally, like what we do. But if she has HIV/AIDS, then this is another reason to look after the mother, especially in third trimester. This is where the infection can pass to the child, and through parturition or delivery, and through breastfeeding, and have outlined how we can prevent HIV or reduce the infection, okay, by certain cares, by pre and post prophylaxis. Then the general wish, or the science now, is working hard to get a vaccine. If you get a vaccine, then that is a long way to the answer of eliminating HIV/AIDS. And the second one is you have to produce more and more drugs, because there are the good evidence that some of the drugs are no longer useful, or resistance is creeping on some of the drugs. If we lose these drugs, then we have difficulty. And luckily, because most of the research on drugs is done in the first world or the developed world, and HIV/AIDS is still a problem in America and Europe, research is going on to produce more drugs. In the tropical diseases, For schistosomiasis, we have one drug available. If you have resistance, then we are in dilemma. For onchocerciasis, we have one drug. For worms, we have two drugs. For malaria, we have artemisinin. So if we lose it, we have problems. But for AIDS, because it's being shared by the tropical countries and non-tropical countries who have the means of investigation and investigation and research, they are producing a lot of drugs on the shelf, which is kept for if resistance arises. So it is control of HIV/AIDS is a responsibility of everybody, not only doctors, nurses, people working in health system, but also religious people, activists in the community, and almost everybody, mothers, for again, mothers for their children, and others, friends for advising their friends, wives advising their husbands, and husbands advising their wives, and then the homosexual is another story for control of HIV/AIDS. With that, I think I've finished with HIV/AIDS at least for the time being, and I wish you good luck with your examinations. I know 27 is now will be embarked on their final sixth examination, and 25 25 is going to get into the examination in the first week or second week of March. So it's good luck for everybody. And thank you very much for being with me.